Good evening, everyone, and we thank you for joining us for Season 5, Episode 17 of Doc Talks with Dr. Forrest Tennant and friends. We have some really exciting things ahead of us this evening. We're looking forward to it. So, Doc, we'll go ahead and let you take it away. Thank you so much.
You can hear me now?
Yes, sir.
Yeah.
You're on the air. Thank you so much.
All right. Thank you, Jamie. Tonight, we're going to focus primarily on education on arachnoiditis. It's a little hard to, it's easy to forget that this show that started a couple of years ago was actually started by Arachnoiditis Hope. And we've gotten off into, including our good friends who have RSD and small fiber neuropathies and head traumas and a lot of other causes of severe intractable pain. And we've had a good expert panel who's been working on some advocacy. I know here tonight, Pat Irwin is watching, and she's allowed me to take 2 or 3 sessions here to do some education as she's putting together our expert panel of Dr. Ibsen and Dr. Guess and some other people. And we're going to have some good advocacy efforts here in a couple of weeks. But in the meantime, I thought it was best that we digress for a little bit because I want to read you a letter that I received here recently from Italy. Real short, and here's what it says. Dear Dr. Tennant, in Italy, there are thousands of people suffering from arachnoiditis with a diagnosis of failed back surgery syndrome. They do not know they have this disease, and the neurologists don't have a clue. Now, that's Italy. Maybe you could write the same thing about Scotland or South Africa or Brazil. But the point here is I want to make is this. When we started Arachnoiditis Hope 8 years ago, arachnoiditis was considered a rare disease. It was even listed on the rare disease registry.
Let me fill in until he comes back.
Okay.
So adhesive arachnoiditis used to be from tuberculosis and syphilis, and those diseases became rare, and so did adhesive arachnoiditis. And not until recently has it taken a surge off the charts.
Thank you so much.
This would be the right time to say, Obi-Wan Kenobi, you're our only hope. we need you to stay alive and keep teaching us. That's what we need from Obi-Wan. And Dr. Tennant is the Obi-Wan Kenobi of pain management, in my humble opinion.
Absolutely.
What is the reason for adhesive arachnoiditis becoming so frequent?
Thank you so much. I appreciate you.
So I'm going to read from this. Handbook to Live Well with Adhesive Arachnoiditis. So I make sure I'm completely accurate about what it is. Definitions you must know. Adhesive arachnoiditis. This condition is present when there are adhesions between the arachnoid layer and the nerve roots in the cauda equina. Cauda equina is Latin for tail of the horse. And the way the nerves operate in the spine is they start off solid and then they split into this cauda equina. Adhesions glue the nerve roots to the arachnoiditis layer, and this can be seen on a magnetic resonance image, MRI. Fundamentally, AA is the abnormal gluing together of 2 different body parts, the lumbar nerve roots and spinal canal covering. The arachnoid is the cover or lining of the spinal canal that is scientifically called the thecal sac or meninges. The inner layer is called the pia mater. It is extremely thin and fragile. The outer layer is the dura, which is thick and firm, durable. The arachnoid is the middle layer. It contains blood vessels and inflammatory cells and can become inflamed if irritated or damaged. It is named arachnoid because it's a spidery, thin veil of connective tissue that's easily damaged and highly sensitive with very poor blood flow to it.
it so that
There he is. Welcome back.
Oh, there you are. Yeah. Okay, I know we both just saw them. Dr. Tennant?
Are we back?
You're back.
Yay.
Yay.
Oh, okay. Well, whatever it
Thank you,
was,
Dr. Ibsen.
yeah, we'll go on from there. And I see where Dr. Ibsen was filling in for me admirably here as usual. So, at any rate, let me go on and kind of carry on. In fact, what Dr. Ibsen just read is very, very appropriate. At this point in time, there is some reason to believe that a great deal of back and spine and intractable pain problems are due to the arachnoid membrane, and we really haven't had ways to determine this or to detect this. And I'll come back to that in just a minute, but I'm not positive about this. We've come a long ways. 8 years ago, when we did start the Arachnoiditis Hope, it was really meant to be a task force to put resources and a lot of people together to see if we could not come up with some means of diagnosis and treatment of this terrible disease. A couple of things about it historically that are worth repeating. Arachnoiditis actually was defined in medical dictionaries in about 1873, a long time ago. And it was simply defined, and that definition is the same today as it was then, and that is inflammation of the arachnoid membrane. Now, this diagnosis was made back in those years by autopsy. People would die with it, and they did autopsies, and they saw where the arachnoid was inflamed, red, tied together, that type of thing, and they felt it was infectious, but they didn't know in those days the difference between tuberculosis and syphilis or gonorrhea or meningitis. They just didn't know, but they felt it was infectious, but it was inflamed. So they knew that, and that was about what they did know, and it came to be known as a terrible, horrible disease, and it was frequently called in the 1800s the devil's disease. A lot of you who have it can certainly vouch for that. So I want to carry on for just a moment about what is the arachnoid, and it is a membrane. Dr. Ibsen described it very well. Let me make sure that we're very clear on this, however, because a lot of people have the disease and still aren't sure what it is. At any rate, we're going to have another sophisticated prop here, a tube, okay? Very sophisticated. All right. We're going to play for a minute. This is your spinal cord, spinal canal. And inside this thing, just like your own spinal canal, you've got the spinal cord. And the lining inside is the arachnoid membrane. The outer surface is called the dura. Okay, and it's tough. It's a tough, hidey kind of material. But inside, the membrane is very fragile. It's called arachnoid because in the 1600s, when the Dutch first discovered the microscope, they could see that it looked like a fine spider web, and that's why it was called arachnoid. At any rate, it's a membrane. And remember, membranes are thin, easily torn, easily infected, easily damaged, and that is the arachnoid, okay? Now, what's happened in recent years, which has been quite a discovery, is that the arachnoid, I believe, is the only tissue in the body without its own blood supply. Okay? Now keep that in mind because that differentiates this tissue from everything else. Now, the way arachnoiditis occurs is that hanging down at the bottom of the spinal cord is something called the cauda equina. Now, it's called cauda equina because that stands for horse's tail. Because if you stand up straight and look at the cauda equina, it looks just like a horse's tail hanging down from the rear of the horse. Now, and so normally, and I'll draw one of my crude diagrams. Let me see. Let me see that one. All right, here's the spinal canal, okay? And you have, and in the middle of this spinal canal, right about the middle of your back, the actual spinal cord cuts off and leaves these horses' tails hanging down. There's about 24 of them. Now, what's important for you to know is that that horse's tail are really nerve, we call them nerve roots, but they turn into nerves that leave the spinal canal and go to your big toe, your foot, your ankle, your leg, but it goes to your rectum, your intestine, your stomach, to your bladder, your sex organs, and therefore all of those things are affected when you get adhesive arachnoiditis, okay? Now, there are two kinds of arachnoiditis, non-adhesive and adhesive, okay? Now, the one that we normally talk about is in the lumbar spine. And what it is that if you take this horse's tail what it does, somehow or another, the cauda equina gets glued by adhesions. Adhesions are just sticky material to the side of the pipe of the canal. Okay. And so rather than hanging down, it gets diverted over and it gets attached to the arachnoid membrane. Now, at that juncture, a mass is formed. A mass. It's a mass of inflammation, gluey adhesions, and nerve roots are caught in that trap. Okay? And clinically, what we're trying to do these days is get people to recognize that trap, that entrapment early, because we can do something about it. If we wait too long, that mass hardens, it scars, it calcifies. You get paralyzed, and a lot of bad things happen. So that is lumbar sacral adhesive arachnoiditis. Now, what's really caused this education session to carry on is because we now believe that it is non-adhesive arachnoiditis in the cervical neck that is causing the terrible neck pain that many people have. And the cervical neck pain, I can tell you, is so bad, it doesn't respond to high-dose opioids, electrical stimulation. It is just terrible, okay? And I know a lot of people watching this can vouch for that. So we have two clinical problems out here that are major, and that is cervical non-adhesive arachnoiditis and lumbar sacral adhesive arachnoiditis. Now, what our friend from Italy was saying is that perhaps it's non-adhesive arachnoiditis. It's really the cause of failed back surgery syndrome. Maybe that's what's really causing it. Maybe an awful lot of people who are having to have surgery really have an inflammation of the arachnoid and don't need surgery. In other words, a lot of insight and a lot of inquiry is going on at this time. Now, let's talk about how in the world does it happen that the cauda equina can get stuck to the arachnoid membrane. There are two basic ways. One is direct spine trauma by something that causes direct trauma to the spine, auto accident, war injury, heavy surgery, electrocution. On a lot of industrial people get it, but something that directly impacts the spinal canal with the spinal cord and what have you. Maybe an epidural gone bad, spinal tap gone bad. Those things can all be the trauma that sets it off. That's one set of people who have adhesive arachnoiditis. Now, the big mystery has been, what about those people who have it but don't have spine trauma? How'd they get this? It turns out that in order to develop both cervical arachnoiditis or lumbar, something has to cause inflammation in the arachnoid membrane. So how does it get there? Well, we now know that a number of diseases outside the spinal canal can cause inflammation in the arachnoid membrane and set off the process. Now, we'll be coming back to that concept a little later, but the first thing clinically that you have to do is to determine, did this arachnoiditis occur because of trauma to the spinal cord and the canal, or do they have a disease outside the spinal canal and the arachnoid that caused the inflammation to start? So, but fundamentally what happens, the arachnoid gets nice and sticky and gluey, and then it sort of traps the cauda equina and entraps it in this mass. I want to take you now on a little story journey of mine on how I got into doing this, okay? I'm going to start off with the case that got me into this, and you'll find some of it a little humorous. It's been about 15 years ago. I had a young woman who came to me with her husband, and she had had a delivered her child. The epidurals wouldn't take, and they literally did a cesarean section without anesthesia. And after the surgery, the delivery, she couldn't walk. She couldn't walk. And so, as usual, a severe, rare situation like that, she goes to all the big facilities, USC Keck Center there in LA. She goes to Stanford, I think 2 or 3 other famous institutions, and they don't have a clue on what's the matter with her. They don't know what to do with her. She came to me primarily because of pain and couldn't walk. And so I started the standard intractable pain treatment. I forget what it was, but she needed a pretty good dose of opioids and whatever else we could come up with. But then one day, my secretary said, "There's a woman here to see you." And I said, "Well, okay, who is she? What does she need?" Turns out it's the mother of the girl, okay? And she's from Minnesota. And she comes in and she says, "Dr. Tennant, I'm really here to want to know what you're doing." He says, I have now figured out that my daughter has adhesive arachnoiditis, and how come you're not treating it?" And it's sort of like, what? What are you talking about? She says, "I have studied this, and her symptoms are adhesive arachnoiditis. And if you know what you're doing, you're going to start treating my daughter for it. And on top of that, why don't you study a little bit about Guillain-Barré syndrome? It looks just like that." And I said, "Well," I said, "now that you mention it, you might be right." And you know why I said she might be right? Clear back at about 1980, I had a man by the name of Aldretti, Dr. Alberto Aldretti, incorporated me that I was doing pain work because he got famous he was sort of the father of modern day adhesive arachnoiditis treatment, because he recognized that myodel, the dye used in the spinal columns for x-rays, would give you adhesive arachnoiditis. In fact, later on, it's been kind of shown that John F. Kennedy had that. At any rate, Dr. Aldretti, I got in touch with him, and I actually saw a few cases back then. And in some ways, I was kind of ashamed that I'd forgotten that this young lady who can't walk is probably got arachnoiditis. Well, I know to do one thing for Guillain-Barré, and that's give him steroids. I think I put her on a course of prednisone. She got better in 2 days. And the mother hung around for a few weeks till she started walking. And we actually got her up walking. She still had some pain. And then one day she about bowled me over. She came up to the clinic riding a motorcycle. Well, that didn't do me any good. I wasn't sure anybody with this disease should be riding a motorcycle, but she was riding a motorcycle right there with her husband. And anyway, bottom line was, it taught me a couple of things. Steroids worked, and it was very closely related to Guillain-Barré. And everybody knows that Guillain-Barré has always been viral. And I was doing some viral testing on intractable pain patients at the time, and that's what got me very interested in viral etiologies of these conditions. Well, I had another patient about that time. After I treated her, literally within, as Dr. Ibsen can tell you, we doctors, you kind of, after a while, patients kind of run together. But I had a gentleman come to see me who was actually sent to me by the military. And this had been a decorated Air Force pilot, academy graduate. His parachute didn't open on a jump, and he crashed, and he couldn't walk very well. He came into the clinic. He couldn't stand over about 3 minutes. He had to lay on the floor. And somebody had already told him he had arachnoiditis. And I took their word for it, started treating him. But we didn't have much treatment in those days. But we did a couple of things. We took his hormone levels. I was also looking at hormone levels at that time, and his testosterone blood level came back rock bottom. And so we put him on testosterone. He started feeling better, could start standing. And then we got him on a fentanyl patch and some other opioids, and he started walking. And then he no longer came to the clinic laying down. He came walking in, and to this day he's still going. But he did teach me one thing. Hormone levels have a lot. Arachnoiditis deplete hormone levels dramatically. The inflammation, the pain drives them down. But testosterone, some opioid, and a lot of walking gave him his life back. So that's what we learned about that. And since then, I've taken a number of military people who have had the same condition. And there's a lot of people with this condition down there in those veterans hospitals. A lot of wounded warriors have arachnoiditis. And had another patient I want to tell you about. I had a lovely woman physician one time who had arachnoiditis, one of my early people. And she was a doctor. She did mostly emergency room work. She was pretty disabled. She came in one day and said she'd been having a flare, but she got over it. And she said, and I said, well, how did you get over your flares? She said, oh, well, that's simple. He says, you take Toradol. And I said, you do? So prior to that day, I'd never prescribed a dose of Toradol or Ketorolac. I was scared to death too. I was like most doctors. I'd been told that this is the devil's drug, never use it, it's dangerous, don't even give anybody a shot. She says, oh, that's all BS. She says, you have to use it a couple of 3 times a week to control my arachnoiditis pain. And I said, well, how do you use it? She said, oh, it's simple. It comes in these vials, and you can take it orally, you can take it injectable. She says, that's the only thing along with all my opioids that relieves my arachnoiditis pain. So all of a sudden, we've got cortisone seems to work, walking seems to work, opioids seem to work, Toradol seems to work. Are you getting the picture of all this? So early on, we started getting the idea of at least what you do to give people a life back. But now I want to tell you about my fourth case, and I want to go on and close this out. I had a lovely young woman from Northern California, and she was terrible arachnoiditis. And at that time, we didn't have this state today to where the dosage of the opioids were restricted, and you didn't have all of this controversy. If somebody needed 1,000 milligrams of morphine equivalent, you gave them 1,000. They needed 2,000, we gave them 2,000. This lady, we got her up to about 4,000. Okay, 3 different opioids. Okay, and she still wasn't doing too well. And then I got the terrible call that she died. And the husband called me and the daughter both called me and said, we're here to tell you that she did die last night in bed. And I went on to inquire about it. I said, are you going to do an autopsy or what are you going to do? Well, what happened was, even at 4,000 milligrams equivalent of morphine, we couldn't relieve the pain of arachnoiditis. Okay. Even that dosage didn't work. And the family went on to say, we think she committed suicide. Well, I got the message. It was euthanasia on the part of the family and what have you. Things went quietly, no autopsy, nothing done. And certainly nobody was who was in the know. And you certainly couldn't blame her. And to this day, I talk to a lot of people who are involved with the suicide and what have you. At one time, I actually took some cases from Dr. Kevorkian. He called me one day and said, Forrest, he said, I have some people, if they could just get pain relief, they don't need my service. He considered euthanasia a service. Now, whether you agree with that's irrelevant. But the point is, if you got pain relief, prevented a lot of suicide. So I've had a long, long list of people who have had adhesive arachnoiditis, who've committed suicide, or, hate to say it, and I can't prove it, and I'd never accuse anybody of anything, I'm well aware of what some families have had to do. Okay? And it's been a hunch. Nobody has put those kind of statements in blood or in writing. But as a doctor treating these terrible conditions, you see a lot of things that are tragic. That's one of them. Also, by about this time, some 10 years ago, something else had occurred that was a great motivator to me. And that was, I took an inventory I always carried about 100 people in my little clinic, and it was a charity clinic. They didn't have a lot of money. They paid what they could. It was a charity, and we only took patients on referral from other doctors who didn't know what to do about them. But it dawned on me that the panorama of people attending my clinic had changed. It changed. It wasn't the same as it was 20 years ago. 20 years ago, if you came to my clinic at that time, you'd have seen a lot of pancreatitis. You'd have seen even people still had post-polio neuropathies, a lot of herpetic neuropathies. You'd have seen a lot of diabetic neuropathies. You'd have seen a lot of melanomas that were being treated, a lot of lymphomas being treated. You had a lot of interstitial cystitis. You had sickle cell disease. But all of a sudden, I'm looking at who's in my clinic now. Those diseases are gone. There's been treatment for those. Diabetes treatment had gotten better. There was a treatment for sickle cell, a treatment for interstitial cystitis. Antivirals had come along. In other words, modern medicine had removed a lot of people from the pool of intractable pain patients. But who did we have? A lot of adhesive arachnoiditis looked like number one. Okay, number two, head trauma. Number three, small fiber neuropathies. Number four, Ehlers-Danlos syndrome. And number five, pudendal neuropathy, a big one. And so we had a different group of people in my intractable pain clinic, of which it looked like adhesive and non-adhesive arachnoiditis had moved up to number one. What I want to do now to close this out and then maybe take some questions is to tell you two or three things that happened right after we formed Arachnoiditis Hope. I teamed up with a man by the name of Dr. John Balilo, who at that time was probably considered to be the expert in the country on nervous system viral infections. And anyway, John and I did a series of studies, of which one was we knew about the definition of inflammation of the arachnoid, but nobody had ever proved that. So we took adhesive arachnoiditis patients and did blood levels of inflammatory markers and found out, oh yeah, it's an inflammatory disease. And we published that paper, and it's there till this day. In fact, it's the only paper ever published showing that arachnoiditis causes inflammation. So that was one study. We did a second study. We did systematically take a lot of hormone levels. And we found out that arachnoiditis depletes a lot of hormones you need for healing. And I know on this show we haven't emphasized this enough. But when people get stabilized, they need to measure their hormones. We found out that such hormones as pregnenolone, testosterone, estradiol, progesterone, and pregnenolone go down, and that you may have to replace those if you're ever going to find much relief or recovery from arachnoiditis. And then lastly, we instituted, how do you interpret the MRIs? We had become aware of the fact that the MRI technology, contrast technology, had really advanced. And I had some radiology friends of mine encourage me to study this and come up with some criteria for diagnosing adhesive arachnoiditis on the MRI. Well, first off, I said, well, look, I'm an internist. I'm not a radiologist. And he went on to say, look, don't worry about it. It's always been internists for medical people who figured out things on the MRI. Radiologists just picked it up later. So with some encouragement, I started looking at MRIs. I believe my count now, since I started the MRI review program, numbers over 2,000. So we literally have looked at this, and I've learned a lot of things. I've learned a lot about how that inflammation begins, how the gluing takes place, what it looks like, when you can say somebody has something and some they don't. But I will say this, again, science is a wonderful thing. The technology of the MRI is first class. And I want to stop here right now. If you have arachnoiditis, you need to have your own MRI that you can hand carry in a folder or a binder to your doctors. You need to have your own copy. None of this, it's on a disc, or you can get it on a portal or call my image center. You need to have a copy. If you've got something as serious as arachnoiditis, you need your own MRI showing that you have this. As a matter of fact, if you have those pictures, doctors then are going to be far more prone to prescribe you a benzodiazepine or an opioid or to accept you. When you walk in there and say, oh, some guy in this foundation or somebody said I had arachnoiditis, they're probably going to throw you out as anything. So remember, you need to have a good set of records if you have adhesive arachnoiditis. And I'm encouraging everybody to have a hand carry copy of your contrast MRIs. Oh, and incidentally, you can say what you want about Elon Musk and all his controversies, but Tesla has invented, you never hear about it, they've invented a MRI that you don't even have to have the dye. So the technology of the MRI has gotten much better even, and it's getting better all the time. And when you look at these things, both lateral and axial, you really can see how far advanced you are. And I now also have sadly learned that I can look at them and tell kind of what's our shot at a lot of recovery? What's our shot at near cure? We get a lot of those people. And then you also get those people who have got destroyed nerves, it's calcified, they're bedbound. And I wish we'd have learned about them a long time ago when we might have been able to do more. I want to close this out now by following on what I just said about the MRIs. It gets very hard to answer questions, and I'm going to take questions in a minute, about what to do, because I don't want to be too simplistic about it, but people who have adhesive arachnoiditis of the lumbar sacral spine, you can pretty well divide them into two major groups, okay? And I want everybody out there, some of you may want to write this down. If you have adhesive arachnoiditis and you can still walk, your feet, your legs, and your ankles all work, your bowel still works, your bladder still works, you can extend your arms up high, and you've got a little energy and motivation left, today, with some of the things we've learned, you've got a real shot at a lot of recovery. And cure may not be possible, but near cure is. And we have a number of people that we're following who we've caught their disease at an early stage. And by early stage, I mean they can still walk, they can flex their ankles, they can still have a bowel movement there. They're not incontinent, they can raise their arms, they've got some energy. Those people are in the early category. We can do a lot for them. Now, and I hate to talk about this in a way, but we get people who have had that scarring inside the canal. That mass can solidify, it can scar, it can destroy the nerves, it can calcify them. These people are paralyzed, they're going to need a wheelchair, they may be bedbound, they may be incontinent, both bowel and bladder, sex life is certainly gone, and so they're really debilitated. Now, is there hope for this? There's a lot of people who watch this show who have found a good quality of life, although they've been bedbound and they're in palliative care. Now, these people need top-notch pain care, whatever dosage it takes, whatever drug it takes. They need palliative care. Now, we do have some people that are kind of a cross between the two, and we've seen some people get some good recoveries. And I won't talk about it tonight, but on one of the future shows, we're getting a lot of very good reports about the combined use of hormones and peptides and getting some people to really start getting their legs moving again. We're seeing some of the electromagnetic devices like microcurrent, some of the lasers, they seem to be helping. We're getting some other new ideas on pain treatment. So I don't want to say that if you're in the severe category that you can't get better, you'll have to work at it, but at least we need to have good palliative care. And I know that when we get our expert panel back with Dr. Ibsen and Pat Irwin and Donna Corley and everybody back, we're going to try to even get some better ideas on how we can get those kind of care. So again, I'm going to wrap up the educational part here tonight. You've heard a little bit about the history. It goes back to the 1800s. The arachnoiditis, at least the non-adhesive part, may be very common out there. It may be responsible for not only neck problems, but that may be what most cases of failed back surgery syndrome is. It may be the cause of a lot of the severe back pain. And that there are two causes, and this is a big thing for people, those people who have direct trauma to their spinal cord, and then we have those who have a disease or genetic problem outside the spinal cord that causes inflammation inside the spinal canal. And then lastly, we have two basic categories of lumbar adhesive arachnoiditis, and that is those who still have good neurologic functions and those who have gone so far. Usually they never had any treatment, and it's been awful. They've lived for years with no treatment, mistreatment, been not cared for in a lot of ways in some cases, and that's been tragic. So that's where we're at today. We'll take up this next time. But Jamie, I'm going to turn it to you, and if you've got, we'll take whatever questions we got here for the next few minutes.
Yes, sir. Thank you so much for such a great informational, educational segment. Allison, did you have something that you wanted to ask? I know that you had your hand up early in the show. I wasn't sure if that was for a question.
Yes.
Okay.
Yes,
Allison's always got a good question.
That's right.
Allison
That's
could give this lecture.
Well, I hope you have an answer for this one, Dr. Tennant. So I guess I'm kind of in between the partially bedbound, but bowels and all that stuff still work. But my seepage is so bad in my lumbosacral area, especially over my fusion. And as you saw on my cervical MRI, I also have no musculature left down in the lumbar area either. So now I have like brain sag and cerebral vasoconstriction. I didn't even know that there was a diagnostic condition called reversible cerebral vasoconstriction syndrome. I found an article on cephalgia, International Headache Society from 2024, and Depomedrol makes it extremely worse. Medical marijuana makes it extremely worse. And a lot of the selective serotonin reuptake inhibitors, like the Cymbalta that I take, make it worse. I've noticed lately my 10 milligram Depomedrol shots have been sending me to bed with like a severe intracranial hypotension type headache, but now I have kind of figured out that it is more of the vasoconstriction in my brain. So I guess it's just another step.
Well, I think you bring up a point that it really needs to be said, and that is we have some kind of a drive in medical practice today that one size fits all, okay? That we can literally treat you with a robot or a computer. But in reality, 99 people out of 100 with arachnoiditis do well with Medrol, but there's going to be that one who's going to suffer with it. And that's true of all drugs. In other words, that's why each patient's got to have their own suit of clothes. And you've got to have yours, and it may be different than the others. And that's all right. That's the way all diseases have been. And so this idea that you can just program everybody into one slot really is not true. And you're a good example of it. And you've been intelligent enough, and you read enough, and quizzed enough that you've been able to ride through your rare condition. And so
Right.
and when people today have EDS and they've got genetic defects, they've these different viruses, people are going to need to be treated somewhat different. Okay. And so,
Yeah, that's what the Depomedrol is, like a magic shot. I mean, it helps me with the arachnoiditis pain, and keeping the inflammation down, because of course I can tell when it's going up, between cervical arachnoiditis and severe adhesive in my lumbosacral area. So it does work for me, but now I've got this secondary issue, that, I mean, I know I'd never survive any kind of surgery, and I don't know if there's so much area of seepage in my lumbar sacral area over my fusion site that they'd have to like go from my back and just paste glue all across my whole lumbosacral area, I guess, to try and stop the seepage, if that would even work. But I wouldn't survive the surgery at this point. So I spoke with my primary care doctor, and my medical protocol for following your 3-component has been working for 5 years now. But now I have this situation as I've gone downhill so much. So instead of 10 milligram injection every week, we're going to try going to a 4 milligram pill every 2 to 3 days, if my stomach can handle it and it doesn't affect my brain as bad. We're going to give that a try.
Just 2 comments, and Jim will take another question. You bring up another issue here, and that is with diseases that are going to last maybe most of our lives. I'm a great supporter of medications not taken on a daily basis. I like the idea of 2 days a week, 3 days a week, 1 day a week. Now, that's controversial. You wouldn't think so, would you? But doctors have been so programmed to give daily medication that the idea that you're going to go to 2 or 3 days a week, that's maybe they fear that's giving the patient too much control, but it keeps the drug active. It keeps the side effects down. It keeps the drug working. And so I like to, some pain medicines you're just going to have to take every day to stay comfortable. But these other drugs, if you can take Medrol, for example, 2 days a week, Toradol 1 day a week, these things are quite good. And secondly, this seepage problem you have and what have you, I can't make any guarantees, but I can tell you I'm putting most of my own research time right now into trying to figure out what combination of peptides and hormones can stop some of that seepage.
Awesome.
You see where I'm coming from? I don't have
Yes.
can't give you anything quite yet, but I think I'm getting close. Okay.
Do you think I could back off on my Cymbalta daily and try it every other day as well then?
Well, I would think so, because Cymbalta is one of those drugs that you can get used to awfully quick, and it loses its power. And so a lot of people, Cymbalta has been a great drug for 2 or 3, 4 weeks after they start, and then it quits working. And so, no, I'm a great believer that Cymbalta is one of those drugs that should not be used every day. Okay.
Okay. I'll give it a try. Thank you. You're the
Jamie,
best.
do you have another
You-
question? We can, before
Yes, we sure do. Thank you, Allison. And I'm right here with you, cheering for individualized care, that we shouldn't be placed in a box. We all are individuals, so that's how our care should be. But we do have a question, Doc, from Beth. Says, my doctors won't put me on hormone therapy because I'm factor 5. Does that sound right?
Well, if I knew what factor 5 is, that a blood dyscrasia? I don't know what factor 5 is. And
Neither do I.
Yeah, factor V Leiden deficiency can cause a variability of hemophilia, essentially.
Gotcha.
okay. That's again, you're out of my league on that. But I would just say this, some of these hormones are natural compounds like DHEA, colostrum, pregnenolone. You can buy them over the counter, and they're pretty safe. But again, you're going to have to go with what your doctors tell you about something like that.
Yes, sir. Thank you so much.
Thank you, Mark, for saving me again.
Yes, thank
For
you,
bailing me again.
Dr. Ibsen. Yes, and we've got a question from Donna Wilkes. She has asked that she read recently that one reason for the frequent misdiagnosis of AA is that MRIs really aren't as accurate in detecting the early changes to the arachnoid membrane in AA as is the use of the more potentially dangerous but probably more accurate myelogram. Is that true?
You're asking one of my pet peeves, okay? First off, you have to understand that radiologists historically, when it comes to dealing with the spine, do the x-rays, do the myelogram, do the MRIs to rule in or out a surgical procedure. Okay? Well, surgery helped this. Now, when I look at an MRI, and you got to remember that the adhesive arachnoiditis doesn't occur overnight. It occurs as inflammation creeps into the arachnoid membrane and then also creeps into the cauda equina. Now, I will look at an MRI and I'll see the thickening of the cauda equina, the asymmetry of it, the displacement of it. I'll see where the arachnoid has thickened. Now, the radiologists aren't going to read this. You're never going to see this. The radiologist does not recognize what the disease, chronic cauda equina inflammatory disorder. Why? That's a medical diagnosis in which you can look at the MRI and you can see that the cauda equina is not correct. And if you know what symptoms they are, you can make a medical diagnosis. But you're not going to get an MRI diagnosis, and the myelogram is not going to help you. The myelogram isn't anywhere near as accurate as the contrast MRI done, if the MRI is done correctly. So I know what the issue is. All kinds of people are going to get their MRI, and they don't have adhesive arachnoiditis, and the radiologist is liable to say it's normal. But yet they've got pain everywhere, they're disabled, they're sick, they've got all the symptoms. And that's because inflammation per se does not show on the MRI. Okay? Only somebody who, like myself, who reads a lot of them would say, yeah, that's compatible with symptoms. Okay, now that's medical terminology. Patients and the public and everybody's very unhappy about this. They want a specific diagnosis. I hate to tell you this, you're not going to get it unless you finally can see the nerve root clumping and the mass. And so we're trying to educate people about this. And incidentally, 8 years ago, I never saw a radiologist diagnose adhesive arachnoiditis. I see it all the time now. And I think as time goes on, they'll get comfortable talking in terms of changes that are not surgical. And you'll get a report that says this asymmetry, this thickening, this displacement is compatible with water running down your legs, stabbing pains in the foot, incontinence or something like that. So we're getting a lot of people, and what I don't like about it, now let me tell you the other thing that really is my pet peeve. Somehow or another, we're getting in medical practice where nobody wants to take a blood test. Now, I've just now written up, I'm going to talk about it maybe next week or the following week. When you get kind of stabilized on adhesive arachnoiditis or even non-adhesive, you got about 4 blood tests you need to know what to do next. You want recovery, you want near cure, you're going to have to take some blood tests. Okay? And those people who come back with this radiology report, they've got all these symptoms, and radiology says, oh, no problem. Then you need blood tests, because those blood tests are going to show the autoimmunity, the viruses, the inflammation, the hormone levels. They're going to show these things. And one of my real purposes of this education session here in the next couple of 3 weeks is to get patients and practitioners understanding you've got a serious life-shortening disease here. Don't take it so lightly. This is not a pain problem. This is a disease problem that just happens to have some pain, maybe. And they're too focused on the pain. They need to focus on the disease itself. That takes blood tests. Okay? And so that's the answer to Donna's question. In my opinion, there are blood tests. That's the first thing I'd do. I'd get all those blood tests, and then I can tell you for sure that's cautoequine inflammatory disorder. No, that's adhesive arachnoiditis. You can put together the clinical picture. Now that I've said that, I'm going to close this show out by saying something that I'm very, very tickled about. And some of you may have heard the rumors that the Arachnoiditis Hope has received some sizable grant monies. And part of that money is to be used to try to develop a nationwide system of arachnoiditis educators. We need some people who have the disease, who want to take a little study and become educators about it, so we can develop a referral system, a system to where people know how to get their supplies, know how blood tests are needed. So right now we're on a campaign to start finding people who want to be counselors and educators on arachnoiditis. And I've been blessed that our project has the little financing to throw $1 or $2 here or there to make that happen. So with that, we'll close off tonight. Again, Dr. Ibsen, thanks for bailing me again. Appreciate that. Donna Wilkes, thanks for again. Allison, appreciate it very much. Jamie, it's been a great show. We'll see you next week. Good night.
Thank you all so much. And good night. I thank God for all of you. I'm so thankful for each of you. And I hope to see you again next Thursday, 7 p.m. Eastern. You are
Love
not.
y'all.
Good night,
Everybody.
everyone.
Love you.
Thank you, Jamie.
You.
Bye,
You're not
everyone.
alone.
You're not
Good luck.
alone. We love you
Bye.
all.
Yeah. Love you.
We love you.
Good night. Good night.
night.
Good night, all.
Mm.
Good night, everyone. Thank you so much.
Nice to
Night,
see
Jay.
you.
Good night.
Good night.
Not alone.